Good morning again. Welcome to the second part of the horizontal jaw relation. We'll be discussing the various methods of recording the centric relation. Okay. Now, the methods of recording centric relation are classified according to the various authors. First is the Boucher's classification. That Boucher divided the methods into static methods, which includes the interocclusal check record method and the functional methods, also called as chewing technique. There are four methods in functional, that is needles technique, house technique, Essig technique, and Patterson technique. Then, according to Michael L. Mayer, the centric relation can be divided into four methods: direct check bite or interocclusal record method, then graphic recording, which includes intraoral and extraoral methods, then functional recording, and cephalometrics. Then, according to Hartwell, the methods are functional methods or chewing, which includes needle house method, Patterson method, Mayer's method, and graphic method, which includes intraoral devices and extraoral devices, and physiological or tactile or interocclusal check record method. Then, according to Shari, the methods can be check bite, excursive recording, terminal hinge axis recording, and deglutition. According to Kapoor and Eustace, the various methods can be direct recording, graphic recording, functional recording, and cephalometrics. Then the direct recording are further classified as teeth and occlusion as predominant factors, wherein you can use wax, compound, or plaster, and supporting tissue as predominating factors, which includes again wax, compound, and plaster. Then graphic recording is further divided into extraoral graphic recording and intraoral graphic recording. The extraoral is further divided into extraoral plaster recording after Stansberry, extraoral graphic recording after Geisy, and extraoral graphic recording by indicators after Phillips. Then the functional recording is further divided into mandibulographing after Shanahan, then relator after Hosper, and phonetics after Silverman. Now we come on to the static method. Those that involve first placing the mandible in centric relation with the maxillae and then making a record of the relationship of the occlusal to each other. The advantage is that it causes minimum displacement of the record basis in relation to the supporting bone. The record is made with wax or plaster, with or without extraoral or intraoral tracing devices to indicate the relative position of the jaws. And functional methods, those that involve functional activity or movement of the mandible at the time the record is being made. Okay, this includes Patterson and needle house technique. Both are based on the same principle. That is, the patient produces a pattern of mandibular movements by moving the mandible to protrusion, retrusion, and right and left lateral. The functional methods require very stable record bases. The records will not be accurate unless the bases are stable. The displaceable basal seed tissues, the resistance of the recording mediums, and the lack of control of equalized pressure in the eccentric relations contribute to inaccuracy in these methods. Now, patients must have good neuromuscular coordination to participate in the functional methods of recording centric relations and must be capable of following instructions if accurate records are to be obtained. Now, first we come on to the needle house method. This method uses compound occlusal rims with 4 metal styli placed in the maxillary rim. When the mandible moves with the styli contacting the rim, the styli cut 4 diamond-shaped tracings. Now, the tracings incorporate the movements in 3 planes and the records are placed on a suitable articulator to duplicate the record. As you can see in this figure, this is the maxillary occlusal rim, which is made up of compound, and there are 4 styli which are placed in the maxillary rim. Now, this is the mandibular rim, again made up of compound, and when the patient performs the mandibular movements, there are 4 diamond-shaped tracings which are cut into the compound rims. Starting with the centric relation, then moving to the right lateral, then protrusion, then again centric, then left lateral and protrusion. So this is how a diamond-shaped tracings are cut. Then Patterson method. This uses wax occlusal rims. A trench is made in the mandibular rim and a mixture of half plaster and half carborundum paste is placed in the trench. When the plaster and carborundum are reduced to the predetermined video, patients are instructed to retrude the mandible and occlusal rims are joined together. In this, you can see that the rims are made up of wax and a trench is made in the rims and which is filled with half carborundum and half plaster, and the patient closes it into centric and the rims are joined together. Yeah, this is the cross section of the trench wherein it is filled with the half carborundum and half plaster, and when the patient reduces it to the predetermined vertical dimension, the rims are joined together. And next is the Mayer's technique. This uses soft wax occlusal rims. The tin foil is placed over the wax and is lubricated, and patients perform functional movements to produce a wax path and plaster index is made. Then Shanahan technique. This technique involves placing cones of soft wax on the mandibular rim and had the patient swallow several times. And during swallowing, the tongue forces the mandible into centric relation. And next is the graphic method. The first known needle point tracing was by Hess in 1897. The technique was improved and popularized by Geizy around 1910. Now, Phillips recognized that any lateral movements of the jaw would cause interference of the rims, which would result in a distorted record. He developed the central bearing point, which supposedly produced equalization of pressure. Now, later graphic recording methods used the central bearing point to produce the Gothic arch tracing. Now, Hardy and Pleasure described the use of the Coble balancer, and Hardy later designed a modified intraoral tracer similar to the Coble. Now, graphic method records a tracing of mandibular movements in one plane and forming an arrow point tracing. Now, it indicates the horizontal relation of the mandible to the maxilla. A graphic tracing is to determine that centric relation is made at the predetermined vertical dimension of occlusion. Whenever we record centric relation, it is mandatory that the vertical dimension of occlusion is predetermined and then the centric relation record is made. Now, the graphic methods can either be intraoral or extraoral, and they can also record eccentric relations. Now, graphic methods are the most accurate visual means of making a centric relation record with mechanical instruments, provided that it is checked with interocclusion check record method. These are the these are the tracers. This is the intraoral tracer, wherein you can see that a central bearing plate is attached to the maxillary rim and a central bearing point is attached to the mandibular. And this is how they contact with each other in intraorally. And in extraoral tracer, there is the tracer comes out of the mouth, and similarly again it has a central bearing plate and a central bearing point which is attached to the maxillary and the mandibular rim respectively, and these are the extraoral parts of the tracer, wherein again a stylus is attached to the maxillary and the recording plate is attached to the mandibular. Now, the technique of use, this is called as a height tracing device, the extraoral tracing device. The name of it is height tracing device. Now, maxillary and mandibular casts are mounted on the articulator after taking the vertical jaw relation, tentative centric relations, and phase 4 transfer. Then, the central bearing device is mounted. Now, taking care to centralize the central bearing point in relation to the plate, both anteroposteriorly and laterally. Now, mount the tracing device securely on the rims. Stylus is attached to the maxillary rim and the recording plate to the mandibular rims. Now, this arrangement develops an arrow point tracing with the apex pointed anteriorly. Reverse develops an arrow point tracing with the apex pointed posteriorly. This is the height tracing device. As I discussed, the central bearing plate is attached to the maxillary. The central bearing point is attached to the mandibular rim. And this point just touches the maxillary central bearing plate at the predetermined vertical dimension of occlusion. Now, the tracing device is attached to the maxillary in such a way that the stylus is attached to the maxillary and the recording plate is attached to the mandibular, so that the apex of the arrow point tracing which will be formed points anteriorly. Now the patient should be seated in a comfortable position with the head upright. Now place record bases in patient's mouth with the attached recording devices. Inspect for stability of record bases. There should not be any interference between the occlusal rims when the mandible is moved in any direction. Now lower the stylus to recording plate and determine that the stylus maintains contact with the recording plate during mandibular movements. Now retract the stylus and conduct training exercise with the patient. Place the tips of the index finger under the mandible in the bicuspid area and tip of the thumb under mandible near the chin. Instruct the patient to move the jaw forward, backward, and to right and left while gently applying guiding pressure with the thumb. Knee excursion guide is an aid in training the patients. This is the knee excursion guide, wherein it is seen that the home position is the centric relation position. The patient has to be instructed to move the mandible from the home position to the left lateral position, back to the home position, then uh, protrusive motion, then again back to the home position and right lateral and back to the home position, backward and to the home position. So this is the guide which is to be followed while guiding the patient to move in to record the arrow point tracing. Now, when the patient is proficient in executing the mandibular movements, prepare the tracing plate to record the tracing. Coating medium is now applied. Coating medium should not offer resistance to the movement of the stylus and tracings should be visible clearly. See, this is the recording plate wherein a coating medium is applied. In this case, there is soot, candle soot is applied. So as you can see, there's a this arrow point is formed with the apex pointing anteriorly. Now, other mediums which can be used is thin coating of precipitated chalk in denatured alcohol, soot, or thin film of blue inlay wax. Now, when definitive arrow point tracing with a sharp apex is made, have the patient retrude the mandible to centric relation. That is, the point of the stylus should be at the point of the apex of the arrow point tracing. The apex indicates the centric relation point. See the patient with the extraoral tracing device in place, wherein the stylus is in contact with the apex of the arrow point tracing. That means it is the centric relation position. Now inject quick setting dental plaster between the occlusal rims and allow the plaster to harden. Now remove the assembly and mount the mandibular cast with the new record. Now, once this is done, the space between the occlusal rims is filled with quick setting dental plaster and the whole assembly is removed and then mounted on the articulator with the new record. This is how the plaster record is made in between the occlusal rims. So again, the rims are mounted on the articulator with this new record. A central bearing point attached to the lower occlusal rims parallel to bearing portion of the lower ridge and placed perpendicular to the tracing plate. The tracing plate is centered in the palatal region of the upper occlusal rims. Now we come on to the intraoral tracing technique. Here again the central bearing plate is attached to the maxillary and the central bearing point to the mandibular. And then this there is no extraoral tracing device. This is only the tracing device wherein the record will be obtained. Now, the plate is covered with a thin layer of blue inlay wax. Patient is asked to make mandibular movements. Arrowhead tracing is obtained. A hole may be drilled in the plate at the apex of the intraoral tracing, or a plastic disc with a hole in it may be placed over the apex of the tracing with the help of sticky wax. See, this is how the arrow point is formed intraorally. You can see that the apex of the arrow is pointing posteriorly over here. The hole is used to ensure that the patient's jaw is in the retruded position while the registration is being recorded with plaster. Now, the difference between intraoral and extraoral tracing. Intraoral means the tracing cannot be obtained, while in extraoral, tracings are visible. Therefore, the patient can be directed and guided more easily during the mandibular movements. Intraoral tracings are small, quite difficult to find the true apex, while extraoral tracings are large as they are made farther from the center of rotation and apex is more discernible. Then in intraoral, chances of error is less as the tracing is situated closer to the centers of movements of the temporomandibular joint, and the ability of the subject to perform mandibular movements with the lips in passive contact position. However, in extraoral, errors can be more as the tracing is situated outside the mouth, further away from the centers of mandibular movement. And because of the presence of extraoral tracer, the lips are prevented from meeting each other and remain passive. An intraoral tracer must be definitely seated in the hole at the point of the apex to ensure accuracy when plaster is injected between the occlusal rims. While in extraoral, no hole has to be prepared. Stylus can be observed in the apex of the tracing during the process of injecting plaster between the occlusal rims. Now, there are certain limitations of graphic method. First is difficulty in excessively resorbed and flabby ridges due to instability of the bases. Then difficult in cases of inadequate interarch distance. In patients with TMJ arthropathy, class 2 and 3 jaw relation because of the difficulty to stabilize base and centralize the force. Then another method is pantography. A pantograph is used clinically to measure mandibular movement. Now, there are two types of pantographs. One is the mechanical type, which was developed by Makker and Stewart in 1955, and the other is the electronic type, which is recently developed. The mechanical pantograph requires complex handling procedures in clinical and in laboratories. In addition, the mechanical pantograph's weight and size are cumbersome. This is the picture of the pantograph, which is quite cumbersome and is not really used. Then Cyber Hobby Computer Pantograph, which was developed by Hobo and Takayam in 1983. Electronic pantographs that measures protrusive and right and left eccentric movements by means of a small optoelectronic sensor fixed to the maxilla. And next, we come on to the next method, that is the interocclusal centric relation records. Now, this is the oldest type of centric relation record. Now, Philip Pfaff in 1756 was the first to describe a technique of taking a bite. It is also known as mush or biscuit or squash bite. It was a non-precision record, that is placing thermoplastic material using wax or compound between the edentulous ridges and having the patient close into the material. Now, occlusal rims were later added to the technique to provide a more stable base. One early method was to adjust the occlusal rims to the chosen vertical dimension of occlusion, have the patient close in a retruded position, and attach the rims together for mounting on an articulator. Now, this was done usually with staples or by sealing the rims with a hot instrument. Now, another practice was to soften one of the occlusal rims and have the patient close to a vertical dimension determined by the dentist. Now, in 1954, Brown recommended repeated closures into softened wax rims. Green had his patients hold their jaws apart for 10 seconds to fatigue the muscles and then had them snap the rims together. He then made lines in the rims to orient them after removal from the mouth. Gradually, these procedures evolved into interocclusal records as they are usually done today. Small amounts of wax, compound, plaster, or ZOE paste were placed between the occluding rims, and the patient closed the jaws into centric relation. Now, these improvements were an attempt to equalize the pressure of vertical contact. Now, interocclusal records are now made with a recording medium between the occlusal rims, the trial denture bases, or the complete denture. Normal functioning of the patient's proprioception and tactile sense is essential in making of an accurate record. Now, what are the indications for the interocclusal centric relation record? One is the abnormally related jaws, then supporting tissues that are excessively displaceable, awkward tongue, uncontrolled or abnormal mandibular movements, indicated to check the occlusion of teeth in existing dentures. So this is how the interocclusal records are made. Here, the zinc oxide eugenol is placed between the occlusal rims. And this is how the record is done. And here, the wax is used to do the same thing. This is quick setting plaster. This is ZOE paste. Now, the limitations of using wax occlusal rims. One is the inconsistency of the record because of the inability to obtain uniform softening, thus unequal brightening pressure. Then occluding rims may glide over each other to any eccentric position before, during, or after sealing. And dimensional changes may occur in wax when removed from mouth to room temperature. Then tilting leverages and displacement of bases may be another limitation. And the most serious limitation is individuals may bite rather than retrude the mandible. The various recording materials that can be used are waxes, impression compound, dental plaster, zinc oxide eugenol paste, and elastomeric impression material. So here we'll discuss nick and notch method in brief. In nick and notch method, two things are made. One is the nick and another one is the notch. Now, nick is what? It is basically a diamond-shaped cut which is placed in the canine premolar area in the maxillary occlusal rim, and it should extend up to just the half the width of the occlusal rim. Whereas notch is placed in the posterior region, probably in the first and second molar region, and it is made in such a way that it is made like an inverted tick mark. The anterior portion is vertical and the posterior is slanting. This nick prevents the lateral movements of the lateral sliding basically of the occlusal rims, while notch prevents the anterior posterior sliding of the occlusal rim. Now in mandibular, a trough is made kind of around 1 to 2 mm deep and with a plus shape in the center so that the record is fixed onto it. And then the recording medium, whichever we are using, is placed into in between the maxillary and the mandibular rim, and the patient is instructed to close into centric. Next is cephalometrics. Now, use of cephalometrics to record the centric relation was described by Piot and Schaeffer. The proper centric relation and vertical dimension of occlusion were determined by cephalometric radiographs. Now, this method, however, was somewhat impractical and has never gained widespread usage. Now we come on to the eccentric relation. Now an eccentric maxillomandibular relation is any relationship of the mandible to the maxillae other than the centric position. The eccentric relation records are used to program the articulator to simulate the patient's jaw movements. Now they are classified into protrusive records and lateral records, which can be further into left lateral record and right lateral record. Now, these records are necessary to program an adjustable articulator to simulate the patient's jaw movements. The programmed articulator helps to construct a balanced denture occlusion and restorations in harmony with the functional movements of the mandible. Now, the mandible, first is protrusive relation. The mandible can be protruded to a position anterior to that of the centric relation. This is known as the protrusive jaw relation. Now, in this position, a wedge-shaped opening is observed in the posterior section between the upper and lower occlusal rims. Now, this is known as Christensen's phenomenon. Now, the posterior separation is due to the downward displacement of the condyles as it travels along the articular slope. By recording this gap and transferring the record, the articulator can be programmed to simulate patient's mandibular movements. Now, what are the methods of protrusive record? One is the direct protrusive check record. Now, after suitable training, the patient is asked to protrude by 5 to 6 millimeter and close. The position is recorded using interocclusal check record method and a suitable recording material. This record is made at a slightly increased vertical dimension. Now, graphic method, using the graphic method, using the Gothic arch tracing, the patient is asked to protrude the mandible and close at a point 5 to 6 mm forward of the apex of the arrow point. Now, this position is then recorded using quick setting plaster or a suitable recording medium. The record is preserved and used to program the adjustable articulator. Then lateral jaw relation. Mandible can also be moved to the left or right sides. The relation of the mandible to the maxilla when it is moved to the left or right of the centric relation are known as lateral jaw relations. Now, when the mandible is moved to one side, a separation may be observed between the occlusal rims on the opposite side. This is the result of the downward displacement of condyle, that is the balancing side, as it travels downward and medially along the medial slope of the mandibular fossa. This is known as Bennett movement. This shows the Bennett movement on the balancing side, where the condyle moves downwards and medially. Now, recording a lateral jaw relation, again, same methods can be used, graphic method, lateral check record methods, and another method is the Hanau's formula, where you can, if you can calculate the protrusive record, the L can be calculated as L is equals to H upon 8 plus 12, where L is the lateral condylar inclination, H is the horizontal condylar inclination in degrees, and but it can be used only with the Hanau articulator. With this, we conclude the accurate determination, recording, and transfer of jaw relation records from the edentulous patient to the articulator is essential for the restoration of function, facial appearance, and the maintenance of the patient's health. Unsatisfactory maxillomandibular relationships will eventually lead to failure of complete dentures and necessitate time-consuming and costly remakes. There is probably no best method for recording centric relation. A method proven to be good for one dentist might fail for another. Both accurate and incorrect records of centric relation have been made by these methods. This means that, irrespective of the method used, subsequent clinical checking and rechecking must be done throughout the denture construction phases. Thank you.